Okay, let's dive right into this highly requested, high-yield clinical review. Today's explainer is laser-focused on one big question. Can you master the 20 hallmark ATI key points to pass the ATI quiz on cerebrovascular accidents? We're skipping the fluff and breaking down exactly what you need to absolutely crush your upcoming exams. By the end of this, you're going to have a crystal-clear grip on the pathophysiology, acute interventions, and long-term rehab strategies that test makers literally obsess over. Let's get to it. We're kicking things off with hallmark point number 1, and it's all about the sheer scale of this condition. We are talking about 795,000 Americans experiencing a stroke every single year. Just think about that. That makes it the absolute leading cause of adult disability in the U.S. If you're working on a busy med-surg or neuro unit, you are going to see these patients all the time. This massive prevalence is exactly why these concepts are heavily tested. You've got to be ready to jump into action the second they roll through the doors. Now, let's untangle a TIA from a full CVA. Hallmark point 2. A transient ischemic attack, or TIA, is essentially a temporary hiccup. It's neurologic dysfunction without acute tissue infarction. The blood flow is briefly blocked, the patient gets stroke-like symptoms, but then, crucially, those symptoms resolve. You have to view a TIA as a giant flashing red warning sign of a bigger stroke coming. On the flip side, hallmark point 3 is the CVA. This brings lasting, permanent neurologic deficits if we don't intervene immediately. Why? Because actual tissue death, infarction, happens due to that prolonged lack of oxygen. Here is our roadmap for today. We're going sequentially through stroke types and risks, recognizing clinical manifestations, acute medical and nursing care, stroke medications and RTPA, long-term rehabilitation focus, and finally, a rapid-fire NCLEX key points summary. Section 1, Stroke Types and Risks. Let's look at how the root cause of a stroke totally dictates our game plan. You absolutely have to know the difference between the two main stroke types. Hallmark point 4, hemorrhagic strokes. These make up about 13% of all strokes and happen when a vessel literally ruptures and bleeds directly into the brain. All that blood takes up precious space, which violently spikes intracranial pressure. Then we have hallmark point 5, ischemic strokes. These are the vast majority, 87%, caused by blockages like blood clots or atherosclerotic plaque. Grasping this distinction is absolutely crucial because the treatments are total opposites. I mean, you would never, ever give a powerful clot-busting drug to a patient whose brain is already bleeding, right? That would be disastrous. Hallmark point 6 is all about risk factors, and you need to sort these into two distinct buckets. Modifiable factors are the things we can actually do something about: hypertension, atherosclerosis, heart disease, diabetes, and smoking. Non-modifiable risks are the cards you're dealt: age, gender, and heredity. When you're educating patients, it's super important to hammer home that atherosclerosis is the big, bad common denominator for a lot of those modifiable risks. Moving to Section 2, Recognizing Clinical Manifestations. Let's talk about what a stroke actually looks like when you're standing at the bedside. Hallmark point 7 is your best friend, the Be Fast acronym. Memorize this yesterday. Balance loss, eyesight changes, facial drooping, arm weakness, speech difficulty, and time to call for help. Picture yourself walking into a patient's room and suddenly you notice their face is drooping on one side. Boom! The clock starts right then. Every single second matters. In the neuro world, the saying is time is brain tissue. Getting medical help instantly is the #1 factor in stopping the stroke in its tracks. Now, remember that motor pathways cross over in the brain. Damage on one side wreaks havoc on the opposite side of the body. Hallmark point 8. Right brain damage gives you left-sided hemiplegia, but it also brings major behavioral shifts. We're talking impulsivity, poor judgment, and left-sided visual neglect. Hallmark point 9. Left brain damage often means right-sided hemiplegia, but these patients usually face severe speech and language deficits, and they act very slow and cautious. Test makers love, and I mean love, giving you a patient's behavior and asking you to pinpoint which side of the brain took the hit. Communication deficits are high yield, so let's get these straight. Hallmark point 10 is receptive aphasia, involving the Wernicke area. Here, comprehension is just gone. They hear you, but it sounds like a foreign language. Hallmark point 11 is expressive aphasia, tied to the Broca area. They understand you perfectly, but it is a massive struggle for them to speak or write their own thoughts. Hallmark point 12 is dysarthria. This is slurred speech purely because the muscles in the face and throat are too weak to articulate. Finally, hallmark point 13 is dyspraxia. This is a tricky one. It's the inability to initiate coordinated voluntary movements, even though they physically have the strength to do it. It's like the brain's starter motor is broken. Section 3, Acute Medical and Nursing Care. Time to jump into the hyperacute phase where your rapid interventions literally save brain tissue. Hallmark point 14 is the famously strict 3-hour window for IV RTPA. Do not forget this. The FDA only approves this heavy-duty clotbuster within exactly 3 hours of symptom onset, and it is strictly for ischemic strokes. So if a patient wakes up with stroke symptoms, they usually aren't a candidate because we have no idea when the clock actually started ticking during the night. The timing is rigid because you have to balance the miracle of dissolving a clot against the terrifying risk of triggering a fatal brain bleed. Your bedside priorities are set in stone. Maintain a patent airway and slap on some oxygen if their sats drop, because hypoxia will rapidly kill more brain tissue. You also have to aggressively cool down hyperthermia. A fever makes neurological outcomes so much worse. But here is the big one, Hallmark point 15. Keep that patient strictly NPO, nothing by mouth, not even a sip of water, until a speech-language pathologist does a formal swallow study. Dysphagia is incredibly common right after a stroke, meaning if you hand him a pill with some water too early, you're risking aspiration pneumonia, which can be fatal. Section 4. Stroke medications and RTPA. Let's pivot to pharmacology and see how they test these specific drugs. For pharm, you have got to know your monitoring parameters for these high-alert blood thinners. Hallmark point 16. For unfractionated heparin, you're watching the APTT, and you must know the reversal agent is protamine sulfate. Hallmark point 17. For warfarin, you're tracking PT and INR, shooting for that 2.0 to 3.0 sweet spot, and its antidote is vitamin K. But regardless of the drug, your absolute #1 priority is watching like a hawk for any signs of bleeding. Section 5. Long-term rehabilitation focus. Once the dust settles and they are medically stable, we shift gears completely to maximizing their functional independence. In rehab, adaptive devices are game changers. Rocker knives, plate guards, scoop plates. These brilliant little tools give patients back their independence when they're trying to eat with one-sided weakness. Plus, Hallmark point 18. You have to ensure thickened liquids and safe swallowing techniques are strictly enforced for anyone with dysphagia. Teach them to sit bolt upright, take tiny bites, and tuck their chin right to their chest when they swallow. That chin tuck is vital to close off the airway and stop aspiration. A quad cane is fantastic for wide-based support when a patient with hemiplegia is relearning to walk. And this brings us to Hallmark point 19. You have to drill it into the patient and their family to always support the affected side properly. Never, and I mean never, pull on a weakened arm to help them up. Since they lack the normal muscle tone to hold that joint together, pulling a flaccid arm is a one-way ticket to a super painful shoulder subluxation. Wrapping up rehab with Hallmark point 20, which is all about your daily hands-on care. For patients with unilateral neglect, who literally do not register one side of the world, usually from a right brain stroke, you have to actively teach them scanning techniques. Remind them to physically turn their head and look at the ignored side. You'll also be doing a ton of passive range of motion to stop contractures, and you'll put them on a strict bowel and bladder routine. Offering the toilet every 2 hours does wonders for retraining the body and preserving their dignity. Section 6, NCLEX Key Points Summary. Okay, let's tie it all together and lock in these high-yield concepts so you are totally prepped. As you gear up for your exams, remember the core concepts. A TIA is your siren warning sign. Ischemic strokes are the most common by far. Symptoms cross over. Right brain injury equals left-sided paralysis. Always rely on BFAST for rapid assessment, and here is a massive takeaway. A non-contrast CT scan is absolutely mandatory the second they hit the ER doors. You have to rule out a bleed before even thinking about blood thinners. Continuing the summary, acute treatment means strict oxygenation, aggressive temp control, and hitting that rigid 3-hour RTPA window. Dysphagia means immediate, strict NPO status until cleared by a pro. And please, don't mix up your D words. Dysarthria is slurred speech from weak muscles, whereas dyspraxia is the brain failing to initiate a voluntary movement it wants to make. To wrap things up, I want to leave you with a real clinical judgment question to test your mastery. Think carefully about this. For the most successful use of RTPA, does it require administration only after an ischemic stroke is confirmed via CT? And does it require IV administration within 3 hours of the exact onset of symptoms? Take a second. Well, if you said yes to both, you are absolutely crushing it. Trust the knowledge you've built here today, keep grinding, and I'll catch you in the next explainer.